I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel Friends. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is fast track to sensible billing. Now, many people don't know that half of all medical care in the United States today is delivered in the emergency room setting. That means that we are paying already far too much for healthcare that is unnecessary. Most of us in healthcare know that the majority of visits that occur in the emergency room setting can easily be handled in the outpatient setting, except we're already paying far too much with hospital rates. Now today, Robert is on vacation, and he needed to be on vacation. So Robert, I miss you, but I'm glad that you're taking a break, and I look forward to having you back again next week. But today we have Dr. Dan. Hey there, Dr. Dan.
Hey, Faisel. Good to be with you this evening.
What a week we've had.
Absolutely. It's COVID's going crazy, but it looks like we've got a vaccine that's going to be approved. Probably, maybe while we're talking this evening, it may be approved. So that's a good thing.
You know, sometimes you wonder, it makes you wonder about just anything getting approved when you have the data like that Pfizer has presented that it's taken so long for it to get approved. But that's a whole other conversation. I mean, we could talk about, with you, I feel like we could talk about anything. I mean, earlier this week, I think it'd be nice to kind of touch on earlier this week, the discussions that you were having with the Starfield Summit.
Right. About the importance of changing resident education so that they're getting training in value-based care and outcomes. I mean, it would be great if doctors were actually getting trained to take care of populations of patients and improve outcomes and lower cost.
That's the future. Residents and interns shouldn't be learning billing codes and CPT codes. They need to be learning how to run the codes and practice real medicine. Well,
that's right.
Today I would like to say that I have a guest, but since the show is Faisel and Friends, I'd like to introduce a friend, a fast friend who's become a fast friend. I have been following Dr. Mahesh Moolani now for quite some time online. He always puts great nuggets of information, and I'm a big fan of his. I reached out to him sometime this last week, and we connected. And Dr. Mahesh Moolani, welcome.
Hi, Faisal. Hello, Dr. McCarter. Nice to be here. Thanks for inviting me. How are you doing?
Doing really well. I must say that one of my favorite things about reading your posts is it's common sense medicine. Yeah. It makes me wonder that, when you're talking about something simple, we spoke about something like an otitis media, and how many times we've all seen as doctors that a patient will come see us one day after having a diagnosis of an otitis media, and they got started on antibiotics, and you see this patient less than 24 hours after they were diagnosed with this otitis media with a perfect tympanic membrane, perfect pearly white tympanic membrane.
Yeah, that's so true. Yeah, that's what I think. I've written multiple posts on otitis media because of that, because I see a lot of abuse of antibiotic, too much abuse.
Of course. Unnecessary prescribing of antibiotics. And then that goes into the same family of overprescribing of brand name drugs, when a generic drug is equivalent is available, and then you can even look into specialty referrals, unnecessary specialty referrals that could easily be managed in the primary care setting. And as well, and I know in your world you have quite a bit of experience in the nursing home.
Oh, yes. Nursing homes are also notorious about this because physicians, when a nurse calls them, they just say, okay, give Cipro or start Levaquin for pneumonia without doing any test. And sometimes you would be surprised there are physicians who do not know how to read a urinalysis. And this sometimes feels bad. Sometimes you feel that they're in a hurry. That's why they're doing it. But nursing home antibiotic uh, abuse is, I don't know if abuse is the right word or not, but usage is extremely high. So we have to work on this always. Today, I'll give you example. Today, one of my friend called me. She's having cough for 3 weeks post COVID. Okay, so for 4 weeks she's coughing, and she told me that, can you call me um, med steroids and antibiotic, and uh, why? Because my doctor always gave me this for my pneumonia, which I get every year. So things like that. So you, I mean, not just antibiotic, even prednisone and dexamethasone. And dexamethasone, it seems like cure for all the evils. You know that.
Yeah,
It's, I mean, back pain, you get dexamethasone. I mean, all the back pains. If you go to ER, you get dexamethasone. All
that's
kinds of back
right.
pain. Doesn't matter what
Yeah,
size
what
the
was
back pain is.
the quote I heard about steroids is they're the drugs that'll make your patients feel so good they can walk to their own autopsies. So it will make you forget about your ills, but it can actually cause problems too.
Mhm.
Absolutely. And I think part of it is that when, especially from the emergency room setting, when you have people going to the emergency room setting for, say, something like a low back pain, right? They're expecting an emergency room response for something that shouldn't have been treated in the emergency room setting in the first place. And so the emergency room, the hospitals have designed a fast track system in every emergency room across the country, right? Because they know already that the vast majority of the care that's delivered in the emergency room, we're talking about hemodynamically stable patients who should be getting their medical care at a different setting. Now, for whatever reason, the patients are going to the emergency room, stable patients are going to the emergency room to get treated, right, for an acute care visit. Now, my question is, with all the technology that we have available today, could we not have a smart billing technology that would identify a population of patients based on stable vital signs, and then a set of diagnosis codes that are outpatient diagnosis codes, and the reimbursement for the hospital for evaluating and treating that patient in the emergency room setting? Let's say it's a type of care that could be delivered in the outpatient setting, instead of, say, for an upper respiratory infection, pneumonia, the cost is about $10,000. Okay, across the board. COPD exacerbations about $15,000. Now, in the outpatient setting, the cost for providing the same treatment, and most of the time with these exacerbations, they have protocols. There's a pneumonia protocol. There's a COPD exacerbation protocol. There's a CHF exacerbation protocol. There's an angina protocol. They have all these protocols in place. And if you look at, for the pneumonia, many of the pneumonia protocols, you're looking at chest X-ray, Rocephin, azithromycin, maybe Duoneb, Solumedrol, acetaminophen, EKG, and normal saline, right? and maybe plus or minus a little bit more based on what they're seeing there. The cost of that in the outpatient setting is less than $10. If you add even the cost of a 2-view chest x-ray across anywhere in Florida and Tampa, you're looking at about $15 for a cost of a 2-view x-ray. Acetaminophen costs less than a penny. Azithromycin, 40, 50 cents. Rocephin, again, another 70, 80 cents. A cost of normal saline, about $1. This is ridiculous that we're paying $10,000 for something that literally costs less than $10. And then the insurance ends up paying $6,800, $7,000. What are your thoughts?
Well, Faisel, what do you think about, there's that piece of it, but there's also the piece, I used to, back in my younger days, I would moonlight in the emergency room, and I was basically thinking 2 questions when somebody showed up. Did I get them up in a bed or out the door? And it was always easier to write a prescription to send them out. And then, it was after I'd done it for a month or so, I started getting these letters from the medical director that I wasn't ordering strep tests for everybody with the sore throat. And it's like, well, they didn't have a fever. They didn't have any exudates on their tonsils. They were coughing. It wasn't strep. I didn't need a strep test to tell me they didn't have strep, but yet their quality measures said that I had to do a strep test. So, don't you think part of it is getting people in the right location to begin with? How many people go to the emergency room because, 1 out of 5 people are in collection for medical bills. The doctor's office won't see them because they have an outstanding bill. But every emergency room has to see everybody that shows up. But they still generate bills, and they put these people further in debt. So because I've got a $100 outstanding bill from a primary care doctor, I can't see the primary care doctor, but I go to the emergency room. Now I'm getting $1,000 for what should be a $20 bill, right?
Absolutely. And they encourage it. There's a culture of encouraging this sort of behavior, of driving patients from the primary care setting into the specialty offices, and from the specialty offices into the hospital system itself. What's the percentage now of practices, outpatient practices, that are owned now by hospital systems? I think it's somewhere up above 60 or 70%. Isn't that right?
That's a big number.
Yeah.
Yeah.
So
if 60-70%, that's a huge number.
Yeah. So if you have 60-70% of the outpatient practices are owned by the hospital systems themselves, what do you think is going to happen on a long weekend when the practices are closed? What's the message they're going to be getting? If there's any medical emergency, go straight to the emergency room.
Oh.
And so you're right. You're absolutely correct. It's a system itself. It's a system that is transactional, meaning that there needs to be something that drives the encounter. It's the mentality of the chief complaint. So you'll have a patient who has the COPD, they have CHF, they have diabetes, they have God knows what's going on, but the chief complaint is low back pain. So the primary care doctor or the doctor in the outpatient setting is handling the chief complaint, writing a lovely note on around the chief complaint, having all these clicks with the HPI and the review of systems and the physical exam, ultimately getting down to the assessment and plan. And meanwhile, there was no time left to address the things that's going to cause the patient to go to the emergency room in the first place. And so there's a shift. So when you have 95% of the country practicing in a model that is transactional or fee for service, this is what's going to end up happening. The patients are going to end up going to the emergency. Well, they'll end up needing to go see several specialists, or they'll go to the emergency room setting. I'll give you an example tonight with my aunt, my own aunt. I don't know, Dr. Dan, if I told you about a week ago, my aunt was having symptomatic hypertension. Now, she switched health insurances. And because of switching health insurances, she now has to establish care with a new primary care doctor. She's in Pennsylvania. Well, she can't establish care with a new primary care doctor until the second week of January.
Yeah,
So, because of the system.
But just because this happens with a lot. Patient change insurance, and insurance sends them the letter that, hey, you have to change your primary care doctor. Or sometimes, if it is Medicaid insurance, the doctor's name comes on the insurance card. Patient has to call the insurance and tell them, hey, you need to change because this is my doctor. And there are some patients who don't care. They say, okay,
Well, but she's someone with means. She's someone with means with symptomatic hypertension. She has really no other option. She
but
called
to
me
go to
again
the
tonight. Yeah, to go to the emergency room, and she's terrified to go to the emergency room. So she's calling me in Florida while living in Pennsylvania. And in fact, she reached out to a family friend in New Jersey who said that he can see her on Monday morning. But I'm just thinking this is just completely out of control. If we had a system that was focused on prevention, was focused on preventing the unnecessary complications. She's terrified of going to the emergency room. She said, "When would you recommend me to go to the emergency room?" And I told her, I said that if I was worried that you are at risk of having a catastrophic event, yes, I would tell you, you have to, of course, go to the emergency room. For whatever the inconvenience is, because that is a necessary emergency room visit.
Yeah.
And then now, we're not talking about the 30 million people who don't even have insurance. We're not talking about the 40 to 60 million people who are functionally uninsured. They can't afford their high deductibles or their copays. So when Dr. Dan just said earlier, 1 in 5 Americans today is in some stage of debt collection because of medical billing. And the number one cause of bankruptcy in the United States today is also medical billing. And it's not happening from the billing from the outpatient side. It's happening because
hospital.
half of medical care is delivered in the emergency room setting. This is exactly why it's happening. And I'm wondering, it would be wonderful if we had a full risk model applied for the country, right? That the country had a model, because right now already with Medicare, 80% of the risk is with the government, with straight Medicare, right? 20% gets transferred over to the patients. And there's a marketplace of private health insurance companies who have these Medicare supplement plans A through J, that the patients can then pay monthly premiums for to have that 20% coverage. We happen to exist in the Medicare Advantage space. And in the Medicare Advantage space, the types of contracts you can have, the types of value-based care contracts, are 3 general types of contracts. You can have no risk at all, which is just shared savings. You can have some downside risk. Now the primary care doctor or the doctor has some skin in the game. Or you can have full or global risk. So we exist in the full global risk model. Now, in the full global risk model, if the number one cause of waste in the country is unnecessary hospitalizations fueled by unnecessary emergency room visits, then the entire system has the incentive to prevent unnecessary emergency room visits, which of course leads to unnecessary hospitalizations. Isn't that right?
Yeah, that's correct.
Now, what would happen? Of course. Now, what would happen if me as a primary care doctor withheld necessary specialty visits because I'm trying to save some money? Patients will get sick. They'll end up in the emergency room.
So how do you change that?
By investing in primary care. The transition from fee for service to the full risk model, or the full risk way of practicing medicine, must be physician led. Period. And not just any doctor. Good doctors.
That's
Doctors
what I
who know the
believe
difference.
in also. Yeah.
Absolutely. Absolutely. Dr. Dan, you told me a story about one of the early papers you wrote on earwax.
Oh, yeah, and really nothing worked better than just plain water when you actually got down to it. And there are all these different tools and stuff. But anyway, I would actually like to hear. I think Dr. Moolani, you said you do a pretty good sized nursing home practice in Owensboro. Is that right?
Yeah, that's correct.
So what kind of care do you find that the elderly get when they wind up having to go to the emergency room? Do you ever find that they get more care than they need, or they get things done to them that actually takes them backwards instead of forwards?
So if it is a patient going from nursing home, And if the nurse sends them a letter or some note that we are sending the patient with certain problem, you'll be surprised so many times that primary concern is not addressed and patient is sent back. And this happens a lot. I think this happens all across the country that a patient is going from nursing home to ER
Oh no.
Oh,
Oh, we
oh,
lost
sorry.
you there for a minute. Oh, but you're
Yeah.
back.
So patient is going to ER because of problem which cannot be handled in nursing home. Many people do not realize that nursing homes are not fully staffed like a hospital, and they don't have physician 24/7 too. I mean, they might physician can do telemedicine, but they are not present. And even if they're present, they cannot get labs stat, they cannot get X-ray stat. So, for example, if patient gets febrile and is short of breath, it is very difficult to get a stat X-ray and CBC, blood cultures, and other labs. It is very difficult. So that's why many nursing home patients are sent to ER, and sometimes if they have gotten some Tylenol half an hour ago, the fever is gone, they're a little bit short of breath, nobody notices that because you need a trained eye to see shortness of breath. If patient is not talking, you need a trained eye which knows, oh man, look at the shortness of breath, because if patient is not talking, he cannot tell you. He might be breathing 630 per minute, but only a very good clinician's eye can see that 30 per minute. Otherwise, you send the patient back, and then patient is coming again after 24 hours. By that time, it is quite late. So,
oh.
I mean, this happens.
And
Uh, um, I mean, I remember once I sent a patient with cellulitis to the hospital, real bad cellulitis. Not, it was getting worse with antibiotics in the hospital, in the nursing home. And the patient whoever saw the patient sent the patient back with the note, chest pain, acute coronary syndrome ruled out.
yeah, I could still remember one of when I was started in practice. There was a patient called me on a Friday night saying that he was having some abdominal pain and he felt like he needed to go to the emergency room. And I talked with him and really didn't feel like he needed to, but he went to the emergency room anyway. He got there, he got all the labs, CT scans. He insisted on staying. He got somebody to admit him to the hospital. He got antibiotics over the weekend. And Sunday night, he broke out in a rash, a dermatomal rash on his abdomen, and he had shingles. He had the most expensive case of shingles that I think I've ever heard of. But Faisal, you talked about how many unnecessary CT scans are done in emergency rooms. What's that statistic that
Oh
you
my
have?
God. If
Nowadays,
you're
MRIs. Nowadays,
yeah,
MRIs also.
it's true. It's true. But CT, so far as CT, if you're over the age of 65 in the United States and you step foot into the emergency room of any hospital across the country, you have a 1 in 3 chance of having a CT scan. Period. And so far as causes of death are concerned, the number 3 cause of death is medical error. Another fact that many people don't know because there's no death certificate that says medical error. And this is true. So, literally, 1 out of 200 people who get admitted to a hospital in the United States will die. Do you know what
Sorry,
the
how
what
much?
the
One out of how many?
1 out of 200 people who get admitted to a hospital will
Oh,
die? And do you know what the risk is
0.5%.
of dying? Yeah. Do you know what the risk is of dying of jumping out of an airplane for the skydivers?
Depends on the. Oh, no.
It's one in 2,000.
Oh, 1 in 2,000?
Yeah.
I was
It's 10.
thinking of doing it. Now I won't do it.
No, it's actually 10 times safer to jump out of a plane than it is to get admitted to the hospital in the United States of America.
But 1 in 2,000 is a big, huge risk. It's still.
And that's the thing. That's a tragedy with perception of hospitals. People think when they think of the hospital or the emergency room, they think it's a safe place. It's a place to go to for healing. And in fact, the hospital systems, yes, obviously the hospital systems provide important care that is absolutely necessary. But what we're talking about here is unnecessary medical care that is very well known in the medical community. I mean, the way I look at nursing homes in our world, in the outpatient world, let's say, for example, we're just talking about pneumonia, COPD. For COPD exacerbation, costs about $15,000 in the United States, right? And what is the treatment? Typical treatment for COPD exacerbation? For
Nebs and
most,
steroids.
Duonebs, steroids. Maybe you'll get some chest PT. Maybe you'll get antibiotics as well. And for most of the patients, they can be treated in the outpatient setting if they had the proper follow-up. Now, what if they cannot? What if you don't feel comfortable in the outpatient setting? Rather than paying for 3 days in the hospital, $15,000, I would much rather pay $350 a night at a nursing home, pay $1,000 for the same care in the nursing home setting. If I was so nervous that the patient couldn't get the treatment in the outpatient setting for whatever reason, if I didn't feel comfortable, if I didn't feel that they were safe, if I felt that it would be better for them to have a little bit more, some more eyes on them just to receive the treatment that they need in order for them to get on their way. That's what I'm talking about when I'm talking about sensible billing practices. I think more and more, especially with the direct primary care movement, people are looking at the costs. With cost transparency, people are starting to see right now how much it costs to have things like imaging, like MRIs and CT scans, being done on the outpatient. I mean, just even seeing the costs of routine lab work. It's unbelievable how you can see through one primary care company, the labs will cost $20. The same labs with another group will cost $200, and the exact same labs can cost up to $400 or $500. This is crazy, based on who's submitting the code, what the insurance is. This is just all. And when you try to figure out, is there any rhyme or reason to any of this? There's no rhyme or reason to any of these billing practices.
Mm-hmm. Yeah, I agree with you. What do you think is prime?
I'm sorry, can you repeat that again?
What do you think about this direct primary care movement? People call it movement. I don't know whether it's a movement or not, but there are a lot of patients who cannot pay the high deductibles and high premiums. So I think it's good from patient perspective. What do you think about this? Is it going to last? Is it going to fizzle away?
Direct primary care. Well, Dr. Dan, you can get started, and then I can kind of chime in.
One of my former partners in practice is doing direct primary care, and I think it's more or less a Netflix model. So it's a subscription model. I think people who can pair the direct primary care with a high deductible insurance plan, I think it makes really perfect sense for them. Because if you get your primary care and then you have the high deductible, then that's an acceptable risk that you're taking. People who just do the high deductible and have no access to primary care, they're still running a pretty high risk. The downside I see to the direct primary care is they don't have as much access to the outcomes because they don't have they don't get the access to the insurance feed like we get in the Medicare Advantage model. But I think the doctors I know of doing direct primary care love the practice, and they seem to enjoy it. It will be interesting to see how it holds up as healthcare changes and morphs over time.
Yeah, it is changing for sure.
It's part of the evolution, right, Mahesh? With medical students and interns learning billing codes.
Yeah, you told me that. I did not know that because I did not learn that.
Me neither.
Even.
And,
So what
we
you
have
told that.
we have interns. We have interns. We're meeting because we do lectures on value-based care and the full risk model across the country. And so we meet interns in the second years, and I will never forget one of the interns coming up to me excitingly telling me how he's memorizing CPT codes and to try to make an impression on me. And he had the opposite effect. I looked at him and I said, "This is
That
absolutely wrong. You, as an intern, your job is not to memorize CPT codes. As an intern, your job is to run the codes. We all
yes.
need to feel that fear in the middle of the night when you're the intern. It all happened to us in the middle of the night. Nobody gets their first experience in the daytime. I would love to meet somebody who had it during the day. It's always at 2 o'clock in the morning, and the second year is not there. And now suddenly you're standing over there with all the nurses and around this patient who's in a catastrophic situation. You got to run the code. That's your job as an intern, not to be memorizing CPT codes. And so when we got to the point that primary care, internal medicine, family medicine, in the first year, these residents and interns are being concerned with billing and coding. I mean, there's only a matter of time before the ones who are out there are being completely inundated with this life of being concerned more about justifying the medical complexity of their documentation for reimbursement purposes than they are with the medical complexity of the patient who is sitting right in front of them. That's where the concern should be. So everyone, we all have our breaking point. And so when the doctors have reached their breaking point, I find myself with in the full risk model. Now we don't even have a billing department. So we are in 10 states. We're opening in Texas in a few months. And actually it's confirmed, by the way, we're going into Michigan next summer. We're going into Detroit. Very exciting. And now we'll be in 12 states next year, and we don't even have a billing department because we take on the full global risk. See, we're not concerned with the billing, the concept of documentation for reimbursement. And so in many ways, I find myself in a similar place with the direct primary care doctors who just got sick and tired of dealing with all the bureaucracy and all the nonsense of the insurance billing game. And they just said, you know what? Forget it. I'm leaving this thing. I'm out. We're both two arrows that are shot out of the same bow. Except
Mhm.
I believe that they have been shot out further away than Dr. Dan and myself. We are still attached to the system. We're still trying to make this system work. Although the outcomes in direct primary care, so far as unnecessary emergency room visits, I've read 20 to 30% reductions in unnecessary emergency room visits, which makes sense. If I'm a consumer and I'm paying $100 a month to have access to my primary care doctor and all the services that are provided there, I would much rather go for any sort of emergency or acute care situation with my primary care doctor who I'm already paying the monthly subscription to, rather than going to an emergency room doctor who doesn't know me from the next person. So,
Mhm.
although they don't have a direct incentive to reduce unnecessary hospitalizations and emergency room visits, because of restoring the doctor patient relationship, they have those outcomes in their favor. But I agree that so far as providing access to all, what will happen to people who can't afford to pay that monthly subscription? And when you think about it, $100 a month to have access to a primary care doctor is a pretty good deal. I pay more for my pool guy who's cleaning my pool, who comes out here once every week to clean my pool, and even more to have my lawn mowed than I would to have access to a board certified primary care doctor. But that's neither here nor there.
And if
In
you
America,
see, 1,200 is nothing compared to the premium you're paying for insurance,
absolutely,
which is very high. This is
absolutely. The
nothing.
average family,
1,200 per year is nothing. Many are charging 900 and 1,000 per year. This is nothing. I mean, for you're paying that is basically 2 months premium.
absolutely. Well, if you look at the average family, the premium for the average family right now in America is $14,000.
Yes.
The premium. So when we're looking at what's driving up the premiums, what's driving up the deductibles and the copays, and the rates of bankruptcy in the United States, the rates of just medical debt debt in general, it's driven by these practices. It's driven by this completely reckless billing phenomenon that we have in the emergency room and hospital settings. If we invest in primary care, and we're not even talking about a ridiculous amount of money. I mean, when we're talking about prevention and efficient and early intervention, you invest in primary care, and then suddenly wonderful things happen. I remember, Dr. Dan, you told me sometime this last year, if you had a town and you put one primary care doctor in that town, the impact of having even one primary care doctor versus having 10 specialists, what would happen on the outcome of that town?
It would improve.
Yeah.
I mean, you would get better outcomes with the primary care physician. With the specialist, you would just get more procedures done. It wouldn't. I mean, people have to. That's one thing. The little town buys all the stuff to have the really fancy emergency room, but now they got to use all the stuff to justify having it there. I mean, that's the reality of it. It's still a business.
If you have a hammer, you see only nails.
That's right. That's right. Well, and I mean, what do you think about the thing that happens, the whole network thing? So the hospital's a network with the insurance plan, but then they hire a group of emergency physicians that aren't a network, and now they're charging 2 and 3 times the going rate for the patients that show up. So a patient shows up there for something fairly small and winds up with a $5,000 bill. I mean, and they're thinking they've looked it up and the hospital's in network. I mean, I don't know how patients, I don't know how to do it. And I understand what's happening.
I was talking to Faisal about it just a couple of nights ago. Isn't it, Faisal? We were just talking about this. How can the hospital be in network and the physician be out of network? That is not right, I think. I mean, this is not right. I don't know why insurance companies allow it or what are the government regulations regarding that, but this is not right. That's for sure.
Corruption. It's just corruption. It's corruption, and there's always been corruption. It's just now, we're seeing it. It's just much more prevalent, and it's easier for us to see. I think the days of doctors kind of looking the other way, saying, hey, the administrators are coming over here. Let the administrators take over your practice. Let them run the practice for you. You just focus on being a doctor. Don't worry. We as administrators will take care of you. Those days are gone. I think now is the time for doctors to become savvy. I think now is the time for doctors to start asking difficult questions, to start engaging in difficult conversations with administrators. And I think it's just about high time that primary care takes back our profession. I think that that the business people and the administrators have had their run with it, and they've for long enough. And it's time that we restore the doctor-patient relationship by focusing on prevention and early intervention. So, Dr. Mahesh, thank you so much for joining us tonight, for taking time out of your Thursday evening to join us to talk about some more sensible practices with billing. And we need to fast track out of the emergency room for our medical care and back into the primary care office. Thank you.
Thank you. Take care. Good night.
And Dr. Dan, thank you so much. What a ride it's been, hasn't it? It was actually Dr. Dan's idea earlier this year with COVID about going live on the internet and on social media. And I remember when he first told me, I said, what is that? And he said, you just, you go onto one of these online, these social media platforms and you click the button to go live and you get to connect and talk about interesting conversations. This is sort of the stuff we talk about on a daily basis. And we hope that to any of our listeners who joined us today, that you found it informative. Remember, 95% of healthcare in America is fee for service. It is a transactional system. It is a reactive system. And I believe that is what is driving a lot of the unnecessary specialty visits, a lot of the overprescribing of brand name drugs when there's a generic equivalent available, and of course, unnecessary hospitalizations, which are fueled by unnecessary emergency room visits. Dr. Dan, do you have any closing thoughts?
I think you're absolutely right. I think we need to get to the relational, proactive primary care rather than the reactive transactional fee-for-service care. Or as one of the, as Dr. Nelson said, it's not fee-for-service; it's fee-for-coding. So, so I think he made a good point there this evening.
Oh, did he make that comment tonight? Dr.
Yes.
Nelson, I'm with you. It's not fee for service, it's fee for coding. I'm totally with you on that one. Mahesh Moolani, you're not a guest, you're a friend. Thank you for joining. And to anyone who listened tonight, thank you for joining us. For more information about today's topic and to explore job opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.